Hello, everyone. Welcome to our webinar today on burnout prevention and what burnout is. And I'm very excited to moderate today this webinar, especially in the Mental Health Awareness Month with the topic, You Are Enough. And I think that's a very nice frame also under burnout. And I want to introduce our first speaker. So we will have two speakers and afterwards a nice amount of time to have a very fruitful open discussion about the topics. And our first speaker is Dr. Irina Guseva Canu. She's an associate professor of occupational epidemiology at the Faculty of Biology and Medicine at University of Lausanne. She is specialized in public health and toxicology and participates as an expert in national and international consortia on occupational and environmental health and leads several multidisciplinary projects. The harmonized definition of occupational burnout based on the semantic analysis and a Delphi consensus in 29 countries was one of them, and she will tell us a bit more about it today also in her talk. Dr. Irina leads a research group at Unisanté, Center for Primary Care and Public Health, and has to manage up to 30 researchers. She says, as a researcher, but also as a manager, she tries to maintain the balance between the good and the not so good in the academic world. And to better achieve this, she's actively participating in the ReMO cost action. So yeah, Irina, it's your stage now. Thank you very much.
Thank you very much. Thank you to all of you who are present here. And I'm happy to share my presentation with you and to share also some personal thoughts about burnout and what should we do to avoid it. I hope you can see my screen. Works. Okay. Very good. So I will introduce the first part of this webinar, which is mostly based on the theory of the available knowledge on burnout in general. The outline of my presentation contains 5 main points. We will discuss first of all about the burnout definition. Then I will present you what are the main stages of burnout development, how can we detect or measure burnout, how big is the burnout problem in our society and in academia in particular, and how we can prevent burnout. So I start with the definition. A paper was published in the Journal of American Medical Association in 2018, where the authors wanted to assess the burnout prevalence among physicians. They identified 182 studies conducted in 45 countries over quite a large calendar period. And among these studies, they discovered as much as 142 different definitions of burnouts. With that, they were unable to quantify prevalence because every definition had its own content. So the authors concluded that finally burnout should be considered as a self-reported job-related syndrome. And for the moment being in 2018, it was impossible to estimate its prevalence. And it was a huge need to harmonize its definition and assessment. And this is quite surprising because the document all physicians worldwide use is the ICD. ICD means International Classification of Diseases. And since the early 90s, everybody used the 10th version of the ICD, where burnout already was listed. And it was listed, why it doesn't work? In the chapter 22, Need for Health Services, under the code Z, and actually it had its own code, Z73.0, called burnout. So since the early 90s, it was possible to classify burnout according to the ICD code. And since 2021, we have a new version of the International Classification of Diseases, which is the 11th version. And in this version of the ICD, burnout is remaining in the same chapter, which is the chapter Factors Influencing Health Status and Contact with Health Services, which includes reasons for which people can contact health services. And in addition to this classification, the ICD-11 provides this statement that I copy-paste here, where it says, burnout is a syndrome conceptualized as resulting from chronic workplace stress that has not been successfully managed. And along with this, the ICD provides some attributes or dimensions of burnout, such as exhaustion, mental distance, or reduced professional efficacy, which seems to characterize burnout. It also says very explicitly that burnout refers specifically to phenomena in the occupational context and should not be applied to describe experiences in other areas of life. Finally, it explicitly states that burnout is not classified as a medical condition. But what is very surprising with this definition, which could appear as a clear and precise, that actually the ICD, the International Classification of Diseases, is nothing more than a coding system, which is aimed to use medical information to make statistics. It has never been aimed to provide definitions of medical terms for which we need a specific vocabulary or a nomenclature. And actually, why it is surprising that they provide a sort of definition of burnout is that we cannot publish so easily here and there the definitions of technical terms, because definitions have an instrumental value and are a useful tool to systematize the knowledge. So when we introduce a new term, actually the definition enhances its formal expressive power. And for the authorized technical terms in specific fields, we should use terminology or a controlled vocabulary where these definitions are listed. I did not invent all these concepts myself and used this book, which is the book of Analytic and Philosophy in Medicine, and which provides all principles of the definition formation for medical terms. So this book says that the definition is a sentence suggesting that a new term should be considered as synonymous with another already known term or expression. And the only exception to this rule, or to the definition of the definition, is the so-called ostensive definition, where the term is interpreted by pointing to an object and naming it. As I can say, I will call you Jesus, or this will be called burnout. It's very important to mention that definitions are different from meaning explanations. Meaning explanations attempt to explore what people understand by a term. Definitions are also different from descriptions. Descriptions are the enumeration of properties or attributes of the term, here, the burnout. So what actually the ICD-11 provided is the list of attributes or dimensions of burnout, not a definition. And meaning explanations and descriptions do not belong to the controlled vocabulary or to the nomenclature, but are part of the natural language vocabulary. And in medicine, the vocabulary, which is the most comprehensive and reliable, is the systematized nomenclature of medicine clinical terms, which is abbreviated as SNOMED-CT. And it's very, very surprising to see how many research has been done, how many attempts have been done to provide a definition of burnout, while since for a long time, SNOMED-CT defines all concepts related to burnout. As you can see, actually, according to this nomenclature, which is the most complete, reliable, and official nomenclature used almost in all countries, that actually burnout is not a true term, but an acceptable synonym of a concept which is called physical and emotional exhaustion state. And we also have in SNOMED the definition of exhaustion. And for both these terms, There is an attribute precised in the vocabulary, which is disorder or finding. Finding meaning clinical finding, corresponding in this case to the lack of energy, for example, or to a general problem. So let's see now, what does it mean, finding and disorder? Why it is called like this? Again, we can consult SNOMED to see the definition of the term. And we know that in the mental health field, the term disease is not used. And usually we prefer to use the term disorder instead of disease. But we can call either syndrome or disorder, all means that it is a disease. And it is also a clinical finding. And we can also add to this some attributes like occupational, which would be related to clinical specialty, or to an occupation, which is a qualifier value of a patient or a person who consult for this clinical finding. So in SNOMED CT, it is very clear what is burnout, what is a disorder, what is a syndrome, and it is defined according to the scientific definition formation, with a synonym of something we do already know. So how can we now make a convergence between what is stated in the ICD-11 and with the definition provided in SNOMED CT? Actually, we need to introduce a new term, because according to the ICD, burnout is an occupational phenomenon which should not be extended to other areas of life. So we need to specify that in this case, it will be an occupational burnout. And then we can introduce a new term, which is occupational burnout with its definition. So for this, we conducted an international study where we reviewed all the definitions, we conducted the semantic analysis, and we also did the Delphi consensus with many experts from 29 countries. And the definition to introduce this new term was, in worker, occupational burnout is an exhaustion due to prolonged exposure to work-related problems. And occupational physical and emotional exhaustion state is an acceptable SNOMED CT synonym. So it was published with more explanation, and you can consult the cited paper to see the definition. Now we have this definition. It is harmonized. It could appear simplistic to some of those who are not familiar with what the definition should be, especially the definition of a technical term in a controlled vocabulary. But actually, within the expression prolonged exposure to work-related problems, we can hear and see many different problematic situations at work, and not only the stress. So we can now raise the question, is occupational burnout an occupational disease? It's clearly for the ICD-11 an occupational problem, but is it an occupational disease? Because the occupational disease actually corresponds to the national definitions, which is introduced in law. And as you can see in this table, in 14 countries in Europe, but also in Europe neighboring countries like Turkey, burnout could be recognized and even compensated as an occupational disease. And this is quite a large number of countries, because 14 out of 37 countries which participated to this survey, it's almost a half of them where it was already possible to compensate. And here you have already some numbers of persons who were compensated for occupational burnout in these countries. So how can we detect and measure burnout? Actually, because it is a clinical finding, as we saw according to SNOMED CT and the controlled vocabulary of medical terms, as a clinical finding, it should be diagnosed by a physician or by a clinical psychologist based on the clinical exam and anamnesis. But to consider it as occupational can also work to evaluate working conditions. Some pretend that we can do medical and biological examinations, like, for example, DNA analysis or measuring of the heart rate variability. But I should say that for these exams, the evidence on their relevance and accuracy is very low. Many use patient-reported outcome measures, PROMs, which are already called scales or questionnaires or burnout inventories. The problem with this that there are too much, and it's very difficult to know which one should be used. Only for burnout, I've identified more than 20 original scales, and many of them were further revised and translated in different languages, which expands even more the number. So if you want to know how to select or to choose the scale which is the best for your context of research or clinical practice, you can follow these guidelines, but it does not solve the problem of the psychometric validity of the scales and the interpretation cutoffs, which cutoffs are used to decide whether there is a burnout or not, whether it is severe or not. And the psychometric validity, as we show in our research, is not provided and not well identified for all of available patient-reported outcome measures. Even for the very widely used ones, as you can see, there are many psychometric properties which were not assessed properly. And for many of these properties, including the content validity, which is the primary property which should be assessed for a psychometric scale, the evidence is mostly very low. So this is a drawback of using these PROMs. And the most important information I must share with you is the purpose of usage of these scales and PROMs, because they cannot be used as a diagnostic tools for which only the anamnesis and diagnostic interviews is relevant. But PROMs can be only used for making screening or assessing the severity of the outcome or the changes in severity of the outcome. And because it is used for screening, you are probably aware of the last recommendation of the WHO World Health Organization regarding mental health at work. And they raise a screening question as a key question and concluded that they could not make a recommendation for or against screening programs. And to clarify you even more, I looked the web page at the Harvard Medical School for postgraduate education, where it is clearly stated that screening may cause harm and may not be the best use of resources, because in the United States, the intensive screening of depression was used based on the Patient Health Questionnaire 9. And the reason of this intensive screening, which is nationwidely conducted and still recommended, is that it was used to put all these identified cases as a depression on medication. So the pharma companies were the big winner of this screening, but it's not sure that the patients or people identified as depressed based on these scales had a lot of advantages for their health management. So how big is the problem? I have quite a precise situation for Switzerland, which is a small country, but with a liberal economy market. So we can probably consider that it could be comparable with other European countries. And we ask Swiss health professionals, including general practitioners, psychiatrists, and psychologists in the nationwide representative study, how many patients in occupational burnout do they have? As you can see from this table, psychologists are the most concerned professionals with a lot of burnout patients among their clients. And the prevalence of these patients is actually 9%. It is lower in general practice or primary care, which is 5%. We also meta-analyzed all available studies in Switzerland on burnout. And when we did the meta-analysis, we saw the burnout prevalence overall of 18%. But if we only restrict the analysis to the clinical or severe burnout, as you can see, it is 4%, and the confidence interval is between 2 and 6%. So we are consistent with what do report our health professionals who treat these people. Another interesting observation is when we only focused on emotional exhaustion, which is according to the WHO and some construct of burnout is the core symptom of burnout, we have the same prevalence, 18%. So this means that it could be a very good proxy to when we work on burnout, but it is clearly not enough to get a clinical severe, and the clinical severe burnout is much more than just emotional exhaustion. Of course, with the COVID pandemic, the situations changed dramatically, and the Swiss data I presented just before were the data before the pandemic. Here we have some statistics from France, which shows that before COVID, the prevalence of burnout of severe burnout in French employees was 3%. So again, we have quite comparable data between Switzerland and France. But since the COVID, we see a steady increase in this prevalence. And this increase is even more and precisely demonstrated in Belgium, where burnout is recognized and where it was coded according to the ICD-10 with a very precise identification among all reasons which justify the work disability or sick leaves. And as you can see in Belgium, burnout was the first cause or diagnosis of sick leaves. And since 2018, it increased by 66%. So it puts it as a winner in this list of the disability reasons among Belgian active population. It is also interesting to see, because in Belgium data are available and very precise, in which sectors we have the problem with burnout. And as you can see, the first sector nobody are aware about is the hospital sectors or medical sector, where the prevalence is the highest, and the increase during the considered period, 2018-2022, is 98%. But I'm sure not everyone is aware that a similar increase was also observed in transport and logistic workers. And although the prevalence is lower, the increase was as high as in the medical sectors, because these workers were essential workers as well. I also have some data on the prevalence during the pandemic, because pandemic actually encouraged many researchers in many different countries to assess the burnout. And we have also international WHO statistics on the increases in all mental health issues, including depression, which is measured better than burnout. So we have some data that among physicians during pandemic, more than half were affected with burnout. In psychiatrists, it's a quarter or a half, depending on how we measure it. In medical students, it was around 40%. In nursing and midwifery students, it's about half of the student population. But we also have data from a systematic review in a low and middle income country in the university students, which is 12%. Also a study conducted in Hungarian and European students, which are PhD and graduated students in the university. This study did not provide the data on burnout prevalence, but assessed the factors, and they saw that burnout was significantly lower among graduate students who had good sleep quality, high level of support from the university, and who are satisfied with their studies and how the university deal with the pandemic. In contrast, the excessive consumption of alcohol, use of antidepressants, being single and hesitating about dropping the studies were significant predictors of burnout, so risk factors. Let's now see how burnout can develop. Depending on the company or the occupational setting, people could be confronted to some challenges and to show some enthusiasm to overpass them or to achieve some goals. So it starts with enthusiasm and sometimes an overinvestment to achieve a goal. Of course, it is dependent on the personality, because there are people who are very perfectionist, very ambitious, and it can last as long as the person perceives a necessary reward, which could be in terms of the salary, of the recognition, or of pride. So the situation could last as long rewards are sufficient. But once the person realized that rewards are not sufficient, and actually this is already called burn-in, when we start to consume our resources more than at the physiologically relevant way. The second phase would be to develop a sort of stagnation and frustration, because rewards are not sufficient to compensate the investment the person accepts in its work activity. So with this step, actually, we can consider that the spiral of exhaustion starts, and this phase could last for several months or years, and it is considered to be the phase where the person denies its suffering on. Then two possible paths were described. One goes through the protective coping attitude, where the person could take some disengagement of his or her work activity and protect themselves. People call it distanciation or maybe cynicism, which introduced this distance towards clients or colleagues. And actually, if this attitude lasts, it could conduct to what is called burnout or brownout, where the hierarchy would consider the person not enough motivated and maybe offer to her or him some less motivating tasks. So these phenomena could be triggered there. The second coping mechanism is to continue to overpass its own frustration, stagnation, and lack of rewards by an overcommitment. So it will be a headlong rush. And this is also something which is dependent on the personal history and work environment and the type of the problem. Someone with some trauma, some maybe antecedent of mental suffering could choose more this disengagement path, and someone who is again ambitious, perfectionist, and motivated can continue to overcommit. It also depends on the work environment. In the environment with challenges, with bonuses to push person to overcommit, this path will be more common than that one. In contrast, situations with harassment, with conflicts would probably be more prone to conduct to this. And of course, the type of problem could also be determined and whether we could manage or not that. In both situations, these coping strategies are known to be maladaptive and will lose to the feeling in a person that she or he loses its professional efficacy. So it will devaluate her or himself. And the result of this would be the demoralization. And this corresponds exactly to what we call burnout, with a complete loss of the self-esteem. But that is why it's also called demoralization. And if the situation is not treated, then the serious consequences in health could be identified, such as major depression or chronic or serious physical illness. So many people consider that there are stages in burnout development or domains or dimensions. So I will present to you, because it was part of this introductory theory presentation. And as we saw in the ICD-11, but also according to some constructs of burnout, there is this first dimension, which is called emotional exhaustion, which starts quite early. Then this coping mechanism is called dehumanization or distanciation or cynicism, according to the authors. And the final stage is demoralization or burnout, or professional inefficacy in a /burnout inventory, but also in the ICD, it is called professional inefficacy. But I call it burnout, and some other authors also call it demoralization or burnout. But personally, I prefer using another staging of burnout and consider it's like a process of its development with the early stage, intermediate stage, and advanced stage. Early stage corresponding to mild burnout, intermediate to moderate burnout, and severe or clinical burnout would be the advanced stage. Psychiatrists, when dealing with major depressive and the burnout behind, call it complicated burnout. So what could be, why it is interesting to consider this staging is because we should have different management strategy according to the stage. And when burnout starts at the early stage, having rest, taking the vacation, and reflect on the situation could be a good solution. When burnout progresses to the moderate form, actually a sick leave could be already prescribed to motivate the recovery, and the reflection with a psychotherapist is highly recommended already at that stage. And when we get a complete burnout, in these cases, most often the sick leave of 1, 2, and even more years is necessary, of course, accompanied with a psychotherapy. So why considering this staging and how they are commonly defined or not by health professionals? This was the question we asked to the Swiss health professionals whose data I showed before. And as you can see, these are the main symptoms that they provided to define the early stage burnout. As you can see, the most important symptom, according to the experience, is the severe sleep problems. So it starts with sleep problems because of the rumination, because of the constant thinking about the problem, because of the trying to find a solution, how to cope with the problem and what to do. And other symptoms that you can see are fatigue, irritability, and exhaustion is not already completely here. Not as we can see it later on. In the intermediate stage, the symptoms reported by the health professionals are again severe sleep problem, but here we can see more clearly the exhaustion, the anxiety, and first signs of mild or moderate depression. And finally, in the advanced stage, which is severe or clinical burnout, you see that the most salient expression is depression, but also exhaustion accompanied with sleep problems, anxiety, and what we can see and what is the most serious for me are the symptoms of suicidality. That's why this condition should be really taken seriously. And this is probably why burnout is classified among reasons to need help, medical help. Now, there are other authors which consider burnout stages by differentiating different burnout subtypes. Like here, for example, these authors propose to call this early burnout with overinvestment as a frenetic subtype, this coping strategy with disengagement as under challenge subtype, and the final, they are agreed that it's completely worn out, so it's a complete depression. So we can share or not this point of view. I am still considering that the staging of burnout according to the symptoms is more relevant to provide advices on the therapeutical management. because we are speaking about theories, there are many theories explaining burnout or supporting the understanding of burnout as a theoretical concept. Here I cited some of them. One very commonly used theory is the organizational theory, based on which the ICD definition of burnout is actually provided. But probably most of you know also job demand resource theory or effort reward imbalance theory, where we can consider the imbalance between the job demands and job resources. And among demands, there are many which are shared in academia, which are time pressure, interpersonal conflicts, task complexity, job insecurity, unfavorable schedule changes for those who do experimental work, for example, like physicists, or maybe those who are doing animal experiments, also quantitative and qualitative workload, and some personal occupational hazards, maybe using some ionizing radiation or other hazards. And among resources, there are individual, which are, of course, skills, which are positive psychological capital, creativity, which is essential for researchers, but also organizational, such as time flexibility, job security, material resources, autonomy, and, of course, rewards. So if we want to prevent burnout, it's better to promote the resources and stimulate them, and of course to work to decrease the job demands to keep a balance. And maybe just a word about one very curious theory, which is emotional contagion theory, which says that burnout can occur in work groups since they are shared beliefs and emotions which are developed via social interactions. And this theory is actually cited for educators burnout or burnout in school teachers, where when there is a couple of teachers out of work because of burnout, burnout spreads to other colleagues. So we can discuss whether it is related to emotion sharing or whether it is due to the work overload, because those who are still at work have to cope with the extra work from the absent colleagues. So these theories have a very rich literature behind, and if you're interested, you can consult it as a reference and other original publications. Now let's see what are the factors which are considered the main risk factors of burnout and how we can prevent it. Again, this is another view of these personal, professional resources, but also some societal resources or risk factors like pandemic, for example, which was a global threat for all sectors of activity, as we saw, and also academia. And of course, to avoid burnout, the preventive strategy should focus on the promotion of resources and protective factors, which are listed here. Either professional or personal or both, and to the decrease of the risk factors. And we can ask, do we have already some proofs or evidence of the efficacy of the intervention on these factors? Actually, we do, because we conducted studies to assess systematically what are the risk factors really related to burnout in longitudinal designs. And we identified that most of factor studies until now are work-related factors. Here they are called situational, and they are green. Remember the code, it will be useful for the next slide. And these are the factors identified from the explanatory theories of burnout, like job demands, decision latitude, job resources, interpersonal relations, insufficient communication, style of the leadership, and all these factors. So they are a big majority of the studied factors. Less than half of factors studied in relation to burnout are individual factors, such as personality traits, self-evaluation, coping strategy, adaptive or maladaptive, also job attitude, and some personal events like leisure or some stressful life events. And there are also a small group of other factors which are work-related interface with work-home or home-work conflicts and some enrichment from this environment with, of course, some intermediate outcomes, which are stress and job satisfaction or job insatisfaction. So the big family of work-related factors are green and individual are blue, and work individual are yellow. And actually the results show that only 13 of 261 studied factors had a significant effect on occurrence or the development of occupational burnout. And the majority of these factors are work-related. As you can see on these small numbers, most of these factors have low or very low evidence on the importance of the influence on or their role as significant protective effects or significant detrimental effects. And if you want to develop the preventive interventions and focus on protective effect, these are mostly individual factors like promoting leisure, adaptive coping, and the positive job attitudes. But we can also work on job-related protective effects like increased job resources and social support. And if you want to make interventions to prevent burnout, focusing on the significant harmful effect, most of them are occupational, which means that the most preventive effort should be done on the organizational or institutional level, focusing on these factors, especially job demands, social hindrance, conflicting communication, emotional demands, and the workload. Also, we have negative job attitudes, which is the contrast of what we have to promote as a positive job attitude, but of course, work stress and the promotion of the work-family balance. And we have also some evidence that intervention works, especially interventions conducted at organizational level, which are here clearly shown as very effective to reduce the occurrence of burnout or its severity. And especially the organizations which are combined and conducted on both organizational and individual level. As you can see, the effect estimate is almost the double of those of organizational level. And just to introduce you the study published last week, which conducted it was a huge effort to review all the reviews and create this evidence map on the interventions which could prevent different mental health. So here, sorry, I only show you the results on burnout and stress. And as you can see, they found clearly a positive effect of mediation, of education or information provision, psychotherapy at individual level, but also at the group level, exercises, and of course, organizational modifications. So we have now a lot of evidence and a lot of knowledge, and I hope that my presentation help you maybe summarize the available knowledge and clarify some ideas and maybe some false ideas. Thank you for your attention.
Thank you, Irina, for this really very well through organized talk. There were some questions, but we would like to have a bigger discussion after Özgun's talk. But there's a very nice question that links the talks of you together from Neha Basnet. Would you like to ask your question yourself, or you want me to read it for you?
Yes, please. Oh.
Okay, so her question is, what I gathered from the burnout stages development is a linear movement from one stage to the other. I'm just wondering, is it one size fits all stages? How about the linear movement? Is it possible that people could move to intermediate stage and reverse back and forth rather than continuously moving forward? So I think it addresses that slide that you really nicely and thoroughly explained us, these different stages of intensity of burnout. Yeah.
Thank you. Thank you for a very relevant question. I think that we can always stop the process by acting correctly on the symptoms. So that's why I wanted to show you that if you start at a very early burnout by taking a vacation, by thinking about the situation, and when you're moving forward and you cannot find a solution, going in, have advices from the psychotherapist to work together with him. This could help, and this could avoid moving to the final stage, which is a clinically advanced form. This is why, considering this stage progresses as a process, I presented to you as a whole process, but you can stop at every process and come back and sometimes go forward. And no, it's not linear, it's not continuous, it could be disrupted, and it could be also stopped with appropriate intervention.